Great pleasure to introduce to our Russian audience and our Russian speaking audience and English speaking audience also. Our professor Richeldi, Luca Richeldi from Rome, Italy. He is very famous professor and he is professor of respiratory medicine. I'm sorry for spelling. Università Cattolica del Sacro Cuore. Yeah?
Well done.
Is it
well
right?
done.
And we have a translation, so I make some pauses. And the head of Division of Respiratory Disease. And sorry for spelling. Fondazione Policlinico Universitario Gemelli. That's right?
Completely. Very well done.
Okay. And I hope that you will deliver a lecture that you previously sent to us your title of the lecture, Respiratory Sequelae of COVID-19, Treatment Dilemma.
Yes, thank you very much for giving me the opportunity to speak about this topic, and I will now share my screen to show you few slides on the topic. I hope you will see my screen now. Is that okay?
Yes, perfect.
Perfect, thank you very much. So there are many treatment dilemmas with COVID-19, and because we know that COVID-19 is primarily a respiratory disorder, that means it is a respiratory virus entering the human body only through the airways, infecting the epithelial cells and then causing an immune response which will eventually resolve the infection. However, we know that coronaviruses, like any other virus, will spread in the body of patients. Now, we are dealing now here with the dilemmas of sequelae of coronavirus infection. And this recent systematic review and meta-analysis pointed out the fact that we have more than 50 long-term effects of COVID-19. And they are reported here in this nice slide. So many patients will report a lot of symptoms after the infection with COVID-19 is resolved. And this is what we call sequelae or long COVID or post-COVID-19. Now, a large number of sequelae are related to the respiratory tract, with 20% of patients reporting cough, polypnea, chest pain discomfort, and some of them having signs of pulmonary fibrosis or reduced pulmonary capacity. And in our hospital, we reported at the beginning of the pandemic that 3 months after resolution of COVID-19, at follow-up, still about 50% of patients reported dyspnea as a syndromic symptom. And this is in many patients supported by the fact that high-resolution CT scan is not resolving completely. Here you see a classical example of a patient presenting at T0, day of admission, with a classical bilateral interstitial pneumonia dominated by ground glass opacities, then getting more severe 1 month after infection, still the patient is admitted, and then resolving and resoluting in 9 months, but not completely. And this example has been reported very well by Chinese colleagues in this paper in Lancet Respiratory Medicine last year. This is a very nice study long-term by these Chinese colleagues performed on 83 patients for 1 year follow-up. And these patients were all non-smokers, never smoker, with no comorbidities. So we have to assume that these patients, in terms of lung function, in terms of respiratory health, were completely healthy before COVID-19. Now, if you look at the 1 year follow-up of these patients, you will see that 12 months, 1 year after COVID-19 infection, still 1/3, 30% of patients, they have reduced diffusion capacity for carbon monoxide, though they still have a damage in the lung. 10% of patients, they have a reduced forced vital capacity, and about 20% of patients, they have a reduced 6-minute walking test. These are the sequelae of COVID-19. So how to deal with that? We have a tool which is high-resolution CT scan. And high-resolution CT scan, as in this patient, which is representative of one of my patients with post-COVID-19 infection, is telling us that in the lung of this patient, there are signs of fibrosis remaining months, several months after resolution of the clinical picture. And very often, these signs of fibrosis in the lung are responsible for the reduction in diffusion capacity, for the dyspnea, and for the reduced exercise tolerance, which is the main problem for these patients. And the lung damage has been substantiated also by our group in a study which is reported in BMC Pulmonary Medicine 2021. This is the population that we studied in our hospital, and you see here that this group of patients, they have a reduced lung function, and these patients with reduced diffusion capacity are the patients that they started with more severe respiratory failure. So these are the patients that we need to follow up for many months in order to see what's going on in their lung. And what's going on in their lung is mainly due to fibrosis. As you know, fibrosis is a very common pathway to organ injury and failure, as reported in this excellent, I would say, review article from hepatologist colleagues actually in the New England Journal of Medicine. And we know that the prototype of fibrosis in the lung is idiopathic pulmonary fibrosis. And to treat this disease, we have drugs. But when we look at the CT scan of the patient will look like this. These are patients with idiopathic pulmonary fibrosis. And you see, it's very different from what we see in post-COVID-19 pulmonary fibrosis, because there is honeycombing, it's bilateral, it's progressive, and to treat this disease, we use two drugs, nintedanib and pirfenidone. And I think it's relatively unlikely that these two drugs will be able to treat the post-COVID-19 sequelae. Why? Because this has been studied in IPF, and we know these are the data for pirfenidone. We know that using pirfenidone reduce the decline in forced vital capacity over 1 year by 50%. But you know that all of these patients, even the patient with placebo or with pirfenidone, they decline over time. It means that they have a progressive disease. And we don't know how much the post-COVID-19 fibrosis is progressive. And the same is true for the other drug, for nintedanib, where you know from the Impulses trial, here 2 randomized phase 3 trial, again, all patients declining, but patients in nintedanib declining less. So the current paradigm that we have in idiopathic pulmonary fibrosis is this one. The patients will progress over time, natural history, red line, and if we treat these patients with the disease-modifying therapy, which currently is nintedanib and pirfenidone, we reduce that disease progression. The question here is post-COVID-19 fibrosis in the lung progressing the same rate of progression as IPF? The initial data that we have is no. And the main reason is because what we see in high-resolution CT scan is very different from what we see in idiopathic pulmonary fibrosis. Again, here is a CT scan of one of my patients with post-COVID-19 fibrosis, still reporting symptoms and reduced diffusion capacity 1 year after resolution of COVID-19. You see that these are David, there is someone speaking. Hello? So you see that these patients still have some signs of subtle fibrosis in the lung, which is very different from idiopathic pulmonary fibrosis, and is more similar to one new entity that we have now in our respiratory medicine definition. And this entity is called, as you know, interstitial lung abnormalities. This is a paper published by the Fleischner Society 2 years ago in Lancet Respiratory Medicine, highlighting the fact that in some patients, incidentally on CT scan, you can see interstitial lung abnormalities, which is not interstitial lung disease. And you look at here. So now these really look, some of them, like post-COVID-19 fibrosis. Some of them will be non-subpleural and non-fibrotic, like these ones, with the type of ground glass opacities. Some of them will be subpleural and non-fibrotic. Some of them will be subpleural and fibrotic with traction bronchiectasis, and some others will be focal paraspinal fibrosis, central lobar nodularities, and unilateral and focal. So this is exactly what we see in post-COVID-19 fibrosis very often. And we know that these abnormalities, they have an impact on mortality, long-term mortality. This is a nice study from colleagues, in particular Matt Haningake in Harvard, suggesting or showing that the presence of interstitial lung abnormalities is predicting increased mortality 5 and 10 years after identification of this interstitial lung abnormalities. So we need to ask ourselves, these patients with post-COVID-19 interstitial lung abnormality, are they going to have an increased mortality in the year to come, and how to prevent it? This is the concept of the spectrum of fibrotic lung disease that, as you know very well, is composed by different entities: idiopathic pulmonary fibrosis, chronic hypersensitivity pneumonitis, connective tissue disease associated interstitial lung disease, sarcoid, pneumoconiosis, other ILD. So are we missing something here? Are we missing the post-COVID-19 fibrosis? And given the numbers of the COVID-19 cases worldwide, how many cases should we expect with that phenotype? And I had the opportunity to review a lot of CT and high resolution from India. And post-COVID-19, as in the title of this nice paper, can really be the tsunami that will follow the earthquake. And we know that most patients will be improving in their lung fibrosis. Some will remain static and some will progress. And that's where we have maybe a role for antifibrotic drugs. And already at the beginning of the pandemic, these colleagues from London, they hypothesized the potential role for antifibrotic therapy in pulmonary fibrosis after COVID-19 infection, not only with the known drug nintedanib and pirfenidone, but also with experimental drugs that are currently tested in phase 2 and phase 3 trials. Now, this is the Italian Drug Agency, and we have currently ongoing more than 70 trials on COVID-19 and post-COVID-19. And I will just to discuss a couple of them with you. The first one is regarding a monoclonal antibody, which is called pamrevlumab. It's a target therapy targeting connective tissue growth factor. And these are the result of a phase 2 randomized double-blind placebo-controlled trial in patients with idiopathic pulmonary fibrosis treated for 1 year. Relatively large study with 50 patients included in pamrevlumab arm and 50 patients assigned to placebo. These are the results for the primary endpoint. You see that after the loading dose of 12 weeks, the patient in the pamrevlumab arm, they seem to stabilize their lung function over 1 year, while all the patients in the placebo arm decline. And these data are supported also by a secondary endpoint, which was visual score of quantitative lung fibrosis. And you see here that the patient in placebo, they have much more progression in the fibrosis in the high resolution CT scan as compared to patient in the pamrevlumab arm, with the reduction at 12 months around 50%, with very little side effect, because this is a target therapy, and this target therapy, as you know, is very specific for one single molecule. In this case, connective tissue growth factor, which is mainly responsible for the production of collagen and fibrosis in the lung. There is now a phase 3 ongoing trial in patients with IPF, placebo-controlled worldwide, but we also performed a study of pamrevlumab in patients with post-COVID-19 fibrosis at the time of admission to the hospital, and we think to report the results of this trial at the next European Respiratory Society meeting next September. Another drug which has been very well known by pulmonologists is N-acetylcysteine, and I'm sure that you are familiar with this study that was published in New England Journal of Medicine 2005 already, the Iphigenia trial. The Iphigenia trial showed that adding high-dose acetylcysteine to a standard of care will reduce the decline of vital capacity, reduce the decline in the LCO, and you see these are the results that we know very well as pulmonologists. And this is why we started just 1 week ago a randomized double-blind parallel arm study investigating the efficacy and safety of orally administered N-acetylcysteine versus placebo, high dose, 800 mg 3 times a day, in patients with a history of SARS-CoV-2 infection and residual interstitial lung abnormalities. We started the study few days ago, and we hope that this study will be a positive one, because NAC, of course, is a very safe and relatively cheap drug that, considering the huge numbers potentially of patients with post-COVID-19 fibrosis, might actually help them to reduce the sequelae of this disease. And with this, I thank you very much for your attention. Spasiba.
Thank you, Professor Richeldi.
Thank you.
Thank you. Thank you. It's a very interesting lecture. And I have some questions, and I think that we have some questions from the audience. So I will start if you not object. So
Yes.
what do you think about the role of oxidative stress in COVID-19 in the acute phase? And can we use high doses of N-acetylcysteine in these patients in acute phase?
I think that the oxidative stress in COVID-19 is one of the major components of lung damage. So this means that probably using an antioxidant, a potent antioxidant like N-acetylcysteine might be very helpful. And this is true, I think, not only for COVID-19, because we have many others, in particular viral pneumonia, that cause a lot of excessive oxidative stress in the lungs. So my answer to your question would be yes, that's a good idea. Let's do a trial and see what happens. This is what we are going to do in post-COVID-19, but also the idea of doing that in the acute phase might be a very good idea.
To my knowledge, I don't know. I know only one study, randomized study, and it was negative.
Yes, but you know, in these studies, in particular in the studies of COVID-19, the study design, the inclusion criteria are very important, and sometimes you have negative results because the study is not powered enough, is not really performed. So I'm sure that you know it's not easy to set up a randomized controlled trial in the context of a pandemic, but that's what we need to do.
Do we have some thoughts concerning maybe genetic variations in these patients and response to N-acetylcysteine and so on?
No, that's a very good question. That's a very good question, because you know that there is currently a trial ongoing in the US. Is the so-called Precision trial, which is randomizing patients with idiopathic pulmonary fibrosis based on the genotype of TOLIP1. So this is probably true for every drug. Every drug is working in a different way in different patients because they have different genetic backgrounds. So if you ask me, what about the genetic background of patient developing fibrosis after COVID-19? Maybe they have a different genetic background, but that's a very good question to keep in mind. That's why we need more studies that also include genetics and genotyping among the characteristics of patients.
Do you have some data concerning genetic variations of glutathione transferase and so on concerning oxidative stress?
Yes, that's also a very good question. There is clearly a genetic variation, and I think that we will have a response from the Precision trial. You know, the Precision trial is currently enrolling patients based on the genotype, but they have DNA from every single patient, which is very good. And I'm really willing to know, also that trial has been slowed down by the pandemic in the US. But now I started again enrolling, and I think that we might have the results next year. So we need to reconvene and see next year what's going on.
So if I clearly understood, we don't have any data concerning genetics and COVID-19, only pre-COVID.
Not that I know, but these are data that they will be definitely very helpful to have, but we don't have them yet. And also collecting DNA in the middle of the pandemic and doing this, I think that's something that will happen maybe in the future. But in the middle of the pandemic, big waves of cases, that's not very easy. I'm sure you know that.
You know that I am intensivist, I'm anesthesiologist, a critical care physician, but you are pulmonologist, yeah?
Yep.
And for me, it's more convenient to discuss mechanical ventilation and so on, respiratory support. But for you, the question for you, what do you think about dividing lung injury in COVID-19 into some subtypes, like organizing pneumonia, like interstitial lung disease, like RDS and so on?
Totally agree, totally agree. I mean, you are an intensivist, and then you know the intensivists, they like to categorize patient not based on the picture. I think there has been a lot of discussion around that, and I think it's a very good discussion. We have different type of lung damage in COVID-19, and I think that it makes sense to use different approaches in different type of disease. So again, I think that's something that we are learning now, and is maybe something that we'll be learning even for other type of pneumonia, not only COVID-19. So distinguish between different type of pneumonia and of lung damage. But I think most of the COVID-19 cases that I've seen so far, they don't really are the typical acute respiratory disease syndrome. There is something different, and I'm sure that you know that. I don't know exactly what it's different, but there is something different.
As for me, it's not a RDS.
I see.
But I don't know what is it. Can you tell? Maybe this patient has had some signs of organizing pneumonia, and I will give him steroids for 1 or 2 months. Or maybe this patient is like idiopathic lung fibrosis, and I will give him an nintedanib and so on.
I don't know. Clearly, it's not like idiopathic pulmonary fibrosis. There is no necrotic, no progression. But at the same time, honestly, I'm not sure that corticosteroids are the right choice for fibrosis. So, because we had such a bad type of response in idiopathic pulmonary fibrosis that I don't think it's a good idea to use corticosteroids. Plus, corticosteroids sometimes they also give a lot of side effects. So I don't know. It's really something that I think is we need to be careful before using a lot of corticosteroids in this patient because honestly, I'm not a believer on corticosteroids. Of course, we pulmonologists and we like very much to use corticosteroids. Also, you intensivists maybe because it's very easy to use, it's off-label, it's cheap. But I don't think it's what is going to really be the most specific type of treatment for this patient.
Do you think that we have some selected patients who will respond on high dose pulse steroids? Maybe patients which is like organizing pneumonia and so on.
Yes, I agree. Yes, I agree. Some patients they behave like organizing pneumonia, and those patients will respond. But my point is that I don't think it's a good idea to use the same amount of corticosteroids in every single patient, because that's not going to be the right approach to these patients. So I think our treatment should be more tailored, more I would say more personalized to each patient.
And what is your comment on well-known randomized studies concerning steroids in COVID, which showed us decrease in mortality in selected patients, oxygen-dependent, mechanical ventilation, and so on?
Yeah, in some selected patient that can happen, but sometimes it's not really happening in most of the patients. So again, I think that we need to be a little bit more tailored, a little bit more specific, which is something that we will be able to do in the next future. So I think that's something that we will definitely be achieving that.
And what about inhibitors of interleukin 6, IL-6 inhibitors?
I'm not sure. I mean, I don't think that these immunosuppressive therapies are really good for this patient, because then this patient knows much better than I do. We know that this patient, they can have nosocomial infection, opportunistic infection, long-term infection. So I'm not sure that knocking off the immune system, like with these human monoclonal antibodies, anti-interleukin 6, anti-IL-1, it's a good idea. And for many patients, they may also be dangerous because they can then develop opportunistic infection. So I don't think it's a great idea. But I may be wrong, because maybe in the acute phase, that's something that you want to use, but not exactly, I think, in patients with they are really at the beginning of the disease, because I'm sure you know that they will be definitely patients that are, in terms of, they might be very susceptible to any type of opportunistic infection. And we know that many of these patients actually will basically develop opportunistic infection long term, and they will be a real source of major morbidity for these patients.
Do you have corticosteroids and IL-6 inhibitors in your local protocols, in your local guidelines?
Yes, we use them, but in local guidelines, but mainly for patients which have a lot of, they have high levels of pro-inflammatory cytokines, like high level of IL-6 in the circulating, or when they have evidence of acute and intense inflammatory response. Otherwise, we don't use them. We don't use them because that's too complicated and it's too dangerous.
What kind of what level? What figure?
It depends
of
from
IL-6?
patient. It depends from patient to patient. It depends very much on patient. In particular, we treat them when we see that the level of interleukin 6 is increasing over time. When they're increasing over time, then that's when we are going to use them.
Do you use simultaneously with corticosteroids, or is a single treatment?
No, we use them simultaneously with corticosteroids, with low dose corticosteroids. That's what we do in general.
Do you use high dose corticosteroids in selected patients or not?
Not really. No.
What is low dose in your clinic?
Low dose usually is between 40 and 60 milligrams. That's what we use for low dose. Low middle dose, that's what you do.
Dexamethasone or what?
Dexamethasone.
Dexamethasone. Yes. And when we're talking about methylprednisolone, what will be?
Methylprednisolone will be up to 100, 200, 400. That's what we do. We can also use 1 gram. You know, that's what we do when we treat acute exacerbation of idiopathic pulmonary fibrosis, no? But that's something which usually is not happening in these patients. They don't look like acute exacerbation.
So if the patient is deteriorating on your standard dose of corticosteroids and IL-6 inhibitors, what will you do?
As usually we try the new antivirals, which is a combination of antivirals. So we use some very sick patient, we also try to use monoclonal antibodies. And monoclonal antibodies, we are just at the beginning of starting them, using them, but they might be a good match for our patients. So that's what we do. But in some cases, unfortunately, there is nothing to do, even if they are profoundly immunosuppressed patient, like patient with lymphoma, with leukemia, or with organ transplant immunosuppression, or if these patients they are very old or with a lot of comorbidities, cancer. But that that will happen anyway. Also with patients with influenza, with any virus. Any virus can kill a patient with metastatic terminal cancer. This is not specific of these coronaviruses. So we also need to be careful of looking at these cases in a very objective way.
So if a patient deteriorating and he was ill for 2 weeks,
yeah.
Will you use antivirals or monoclonal antibodies?
Maybe monoclonal antibodies, because some of these patients, they have the problem that they are not able to produce or to start an effective immune response. So we know that a large part of the immune response against virus is mediated by T cells, not by B cells, not by antibodies, mediated by cellular immunity. But we don't have a way to produce, to give them a cellular immunity. So what we do is we give them the other arm of immunity, which is humoral immunity, which is basically antibodies. And these antibodies, they tend to be very specific, as you know. So I think that still makes sense in this patient to have them with some sort of immunotherapy, because you want to increase their chances of responding, of having an effective immune response, which is what actually is able to produce.
And what about some drugs that, like immunosuppressors, like mycophenolate mofetil or something else, maybe cyclophosphamide and so on?
I think immunosuppressing this patient is not a good idea, I can tell you, because it's okay, yeah, they have an inflammatory response, and when the inflammatory response is not the problem. The problem is that they do not respond and they are immunosuppressed, because the patient that we see today dying, and we have been seeing dying the patient from the beginning, were patient older and with immunocompromission, with immuno deficiency. So that's what we see, and that's meaning that we know that having that type of immunodeficiency is the problem. So to give them immunosuppressor on top of the immunodeficiency, which is the problem, I think it's never a good idea. But that's what I think it's important to consider. We need to preserve the immunity of these patients.
We have one question from the audience about the first wave of COVID-19, and we have some data, maybe fake news, concerning smokers and COVID-19. That smokers have a better prognosis, better outcome in COVID-19. Is it really so?
I don't think that was confirmed. There was an initial bias.
Yeah.
It was an initial bias, but I don't think that smoking is a good idea. It's not a good therapy for COVID-19. Let's put that way.
And what do you think about the role of biomarkers in the selection of therapy in COVID-19?
I don't know, but it's I'm not a strong believer in biomarker in general. in particular in COVID-19. And blood biomarker, I don't think they're very helpful in guiding us anyway. So, no, I don't think it's a good response. But you know, research is ongoing. Maybe we will find one day that there is a super biomarker telling us how to treat this patient. Unfortunately, at the moment, that's not the case.
So you don't use CRP or ferritin?
We use that, but that's very non-specific. No, when you see a patient with very high CRP, the patient is sick. That's it.
Yeah.
You know already that. When you arrive in the ward, you will tell which patient will have a high CRP, right? So that's it.
So you don't guide your therapy concerning based on CRP on other biomarkers, yeah?
No, absolutely.
So you guide your therapy based on clinic.
Yes, basically it's based on clinic. It's based on the type of comorbidities of the patient, types of immunosuppression, types of problem. The patient is an oncologic patient. Patient is a leukemia, is lymphoma. That's what I am looking at. That.
So if you have young patient, 35 years old, no comorbidities, 10 days of illness, progression, oxygen, lung involvement 75%, what will you do?
Usually we treat them, we follow them up, and if they have some type of important comorbidities, then we'll use the monoclonal antibody. Otherwise, it's a follow-up. And Omicron, honestly, is much less dangerous for the lungs.
For Delta, for example, Delta, not Omicron.
We don't see Delta anymore, but for Delta, that would be difficult. So it's important. Be careful and follow them up, and to look for silent hypoxemia, to check on oxygen saturation, and to be able not to try to be to monitor this patient. That's important, because sometimes we see this patient, they will drop in oxygen saturation from one moment to the other. They don't feel that immediately, and that's when you want to treat these patients early. So it's not easy, but I think that monitoring, home monitoring maybe, telemonitoring, is such a good way of taking care of these patients.
But will you start in this patient corticosteroids and IL-6 inhibitors?
Only if they have respiratory failure.
Yeah, of course. Respiratory failure,
yes.
yeah, of course, yes.
Respiratory, yes, because you really want to reduce the problem at the diffusion, right? So that's what you do.
What do you think about high flow oxygen or CPAP therapy?
I think high flow oxygen, we use a lot of high flow, humidified and heated high flow oxygen. I think it's really changing. I think when we can, it's much better than non-invasive ventilation, than CPAP. A lung with an infection, a lung with interstitial disease need to be protected from excessive barotrauma, excessive ventilation. So I think the high flow oxygen is the best first initial step. Then, of course, if the patient is deteriorating, then you have to move on and escalate. But it's a good idea to start with high flow oxygen, which I think, at least in Europe, is a technology now, is a technique which is much more used than before COVID. It's much more widely available, and I think it's something that is, even in the intensive care unit, is more used.
Do you think that CPAP therapy or non-invasive ventilation can injure lungs, can increase lung inflammation and induce patient self-induced lung injury?
Yes, I think it's possible. Lung injury, you know, it's something which is non-specific but can be very dangerous. So the concept of acute lung injury is non-specific of any disease, right? And that's where I think it's important to be monitoring the patient, treating the patient very quickly, and to have an intense monitoring, like in the semi-intensive or in intensive care unit. That's where you need the real monitoring.
So, as I understood, you will start from oxygen, not from
Yes.
CPAP.
No, we start from oxygen, then we move to high flow oxygen, and we don't start with CPAP because, you know, starting with CPAP, it means starting with creating a damage to the lung, which sometimes is needed, but sometimes is not needed. Sometimes you get a good oxygenation, a reasonable oxygenation for the patient with high flow, and then the lung will be much more protected. I mean, protecting the lung, as you know, protective ventilation, but the high flow oxygen are important. Is important because will be the less invasive, less traumatic, and more protective way of giving the lung. Hold on 1 second. Sorry, I have to go in 5 minutes, but
Okay.
we are discussing a lot, right? So where are you based now?
Where is my position?
Yeah, where are you? Where are you working?
Moscow.
In Moscow. Okay.
Sechenov University as a professor of pulmonology
Intensive
department. Pulmonology department professor. Professor Avdeyev is my chief.
Okay.
And I'm simultaneously working in Pirogov University in Moscow
Okay.
as a head of intensive care department.
So you are very busy.
Yeah.
Okay. So thank you very much for listening to my talk.
Thank you for this interesting lecture, for your dialogue. Thank you for your time.
Thank
And
you to all the colleagues from
have a
Russia.
nice evening. Дорогие друзья, у нас мы послушали с вами лекцию профессора Ричелди, и нам удалось что-то у него выяснить, как происходит. На самом деле вопросов осталось достаточно много. К сожалению, занятость профессора не позволяет его допросить с пристрастием, как бы нам хотелось. Но вот пришел после уже завершения один вопрос: как снизить вероятность образования фиброза после перенесенной пневмонии при ковид? Ну, я думаю, что как раз этот вопрос профессор Ричелди освещал, и он говорил, что исследование сейчас как раз проходит свою третью фазу, да, то есть пока эти исследования продолжаются, и мы не очень на самом деле понимаем, как это сделать. Но будем надеяться, что, может быть, препараты, которые следуют в этой проблеме, дадут какой-то, прольют свет на можно это сделать или нельзя это. Я прошу прощения за нашу сегодняшнюю задержку, связанную с накладкой вебинара у профессора Ричелди. И мы с вами встретимся достаточно скоро, я надеюсь, в наших школах. Не пропустите анонсы. Спасибо за ваше внимание. До новых встреч.